Now, this is a case summary of a 70-year-old male who presented with shortness of breath on exertion going on for last many months. He also complains of some memory loss and tingling sensation in his feet. On examination, he looks pale and has an absent ankle jerk. His CBC shows a hematocrit 32 and an MCV of 115, which is high. So what are the possible diagnoses and what is going on? Now, what's the possible diagnosis? This patient has features of heart failure. They may be because of the anemia he has, because the hematocrit is quite low. Since the patient has absent ankle jerk and tenderness, and the tingling sensation in the feet, that indicates neuropathy. This patient has a high MCV, that is 115. This patient may be suffering from megaloblastic anemia. Megaloblastic anemia may be because of vitamin B12 deficiency, which may be pernicious anemia, or vitamin B12 deficiency for some other reason. So this megaloblastic anemia may not only be because of pernicious anemia, it may be for some other reason as well. Then patient may have folic acid deficiency anemia. So these may be the reason the patient has high MCV anemia. There are other reasons for high MCV anemia. For example, patient may have hemolytic anemia, patient may have hypothyroidism, maybe chronic liver disease like cirrhosis of liver, or if the patient has myelodysplasia. So since this is an old patient, the two differentials are more important, the megaloblastic anemia and myelodysplasia. How would you differentiate between these anemias? You see, macrovalocytes with hypersegmented neutrophils, this favors B12 deficiency or folic acid deficiency anemia, that is megaloblastic anemia, because in other large MCV anemia, the cells are usually spherical. They are circular, they are not oval. So macrovalocyte with hypersegmented neutrophils, this is most likely pernicious anemia. The reticulocyte count in pernicious anemia is usually low despite the bone marrow is active. Some of the patient may show pancytopenia. Peripheral counts may be low, hemoglobin may be low, platelet may be low, the WBCs may be low. So all three lines may be low. There is increase in LDH, bilirubin, iron, but it's not present in all patients. So this may be non-specifically elevated, doesn't give us clue about the diagnosis, because LDH may, for example, be increased in hemolytic anemias. Similarly, the bilirubin may be increased in hemolytic anemias. So it may not be of value differentiating between different types of anemias. But if you have a macrovalocyte with hypersegmented neutrophils in the peripheral picture, this is most likely B12 deficiency anemia. And you see B12 and folic acid levels are low. When we do the serum B12 level, it may be low, or if the patient have folic acid deficiency anemia, the folic acid level will be low. We generally do serum folic acid levels or red cell folate. The red cell folates are actually the true indicators of folic acid deficiency, and the serum folic acids, they fluctuate with a lot more conditions, so they're not very diagnostic of folic acid deficiency. If we can get the red cell folate, that may be more important in making a diagnosis whether the patient has folic acid deficiency or no folic acid deficiency. Then, if the patient has large cells and they are round macrocytes, then we look for the presence of feature of other disease as well. For example, patient is hypothyroid, or patient has hemolytic anemia, or sometimes the patient may have myelodysplastic syndrome. So look for the presence of features of those conditions as well. So this is how we see a patient who is presented with large MCV anemia. It is megaloblastic anemia, or it may be non-megaloblastic anemia. Megaloblastic anemia has macrovalocyte with hypersegmented nuclei, while the other type of large cell anemias are rounded macrocytes, and there may be features of the disease causing those conditions present in the patient.